I'd like to next introduce Dr. Mike LaPosada from Vanderbilt, who's going to talk to us about the diagnostic management team. Mike.
Thank you. Thanks, Ray. Well, I'm delighted to be here. I think it's my 7th visit. And this story began in 1984 when I was a resident at Washington University. And I had a medical resident ask me to help him work up a prolonged PTT, and I was stunned. He had no idea how. And I thought, if you don't know that, somebody's getting hurt. So I tried to get the residents involved to be the basic functional unit to say, here are the tests you need, and this is what the test results mean. And couldn't get any traction. What could I do as the chief resident? So I went to Penn. I got my first job. In 1988, we started doing interpretations in my own lab, the coagulation lab. And in about 3 months, the chief of hematology came over and said, stop doing that. And I said, why? He says, because that's the way we earn all our revenue. We go see patients with prolonged PTTs. And if you tell them the answer right away, we lost our money. I said, but what if we stop them from getting fresh frozen plasma and then they don't get non-A, non-B hepatitis, which is what we called it at the time. We still need the consult. Okay, professor of medicine, assistant professor of pathology. I backed down, I went to the MGH, I became the head of the clinical laboratories. And this time it was either going to go forward, make it, or we weren't going to do it at all and I was going to be somewhere else. So around 1993, after I'd been there 4 years, we built up enough of an educational program. And by 95, we were doing interpretations of coagulation tests that were patient-specific, this isn't a cookie-cutter thing, and expert-driven. We knew as much as the people on the other end, if not more. That spread to the blood bank, and it pretty much stopped there. And this was the basic functional unit. So we're supposed to provide advice, right? We're the doctors. How are you going to do that? Well, let me tell you what the basic functional unit is. Here it is. This is coagulation. So in 2008, Vanderbilt said we'd like to try to do this across the whole of pathology, and that's what I'm going to tell you about. It now has a name. The basic functional unit is the Diagnostic Management Team, or the DMT. And I'm going to tell you how it works, and I'm going to tell you how it is difficult to implement in many places because of barriers. So let's begin. I have no financial disclosures, and I have to push the, they told me I could click this thing. All right. All right, so what are we going to do? We're going to talk about the presentation of the clinical problem. I'm going to tell you about the DMT at Vanderbilt, what it does and how it was created. I'm going to tell you about existing and planned diagnostic management teams. Right now we have 5. We're on our way to get 11 or 12 by the end of the year. Coagulation rounds in some detail about how it works and some concluding thoughts. And first, the presentation of the clinical problem. Lots of you are familiar with this slide. George Lundberg put this total testing process together. This is the clinician's brain. And we in laboratory medicine are supposed to deal with all these steps. And what I realized in 1984 is that they don't know what test to pick in the first place. And the other problem is that when you tell them that they have a factor 12 of 0%, they think that you're supposed to bleed and they're going to give you plasma, and that's all wrong. So we created 2 terms. One was pre-analytical, and pre-pre because this was already pre-analytical right up to the analysis. So this is the pre-analytical problem. And then we created the term post-analytical because they actually have the data, they just don't know what it means. So we have pre and post analytical problems. I became part of a group in 2008 sponsored by the CDC called the Clinical Lab Integration into Healthcare Collaborative, or the CLIC group, and we have several projects ongoing, and one of them is being led by Brian Smith, who's Chief of Laboratory Medicine at Yale. Look at these data. This is amazing. We're now surveying medical schools to find out how much laboratory medicine doctors get. And here it is, 60 to 300 hours of anatomic path, an average of 9 hours of laboratory medicine. And in laboratory medicine, it's often not taught by somebody in laboratory medicine, and there's no exam, right? So this is a very different paradigm. And so what happens when you graduate? Well, let's see. for anatomic path after you graduate and you become a primary care doctor, you spend no time looking through the microscope, right? That's what's taught in medical school, by the way. And the frequency with which we ask those people to order tests is daily. Something's wrong. And so here we are, 2012, right? Dozens of imaging modalities, lab medicine that is totally ridiculous. So here I am. I look at the whole of laboratory medicine, but my research effort is fatty acid abnormalities and cystic fibrosis. If you look at that gene, the cystic fibrosis gene, there's over 1,800 mutations. People say, oh, really? We just look at about 40. Well, wait a minute. There are people showing up with all these different mutations. In fact, if you have a gating mutation, class 4, a drug appeared in the last year, Kalydeco, which can give you a cure. The age of death is 37. So we have a medicine that can let you live for the rest of your life, but we have to know if your mutation is a class 4 mutation for a gating mutation. That's a doggone important question to figure that out. So just before we said, oh, we just need to know 1 or 2. No, I'm sorry, we need to know what they are. And in anatomic pathology, things begin to expand too, but let's face it, we got a tumor and we got a gene mutation, and those babies are running together. So we're going to have to put those pieces together to really give an answer. So why haven't all the diagnostic specialists convened to synthesize their findings? You know what we are still doing? We are taking a puzzle, 16 data points. We're taking all those individual data points and we're throwing them at the clinician. Why don't we, the diagnostic experts, take the 16 pieces of the puzzle, put them together, hand them to the doctor and say, here it is. Your patient has cystic fibrosis. I mean, why not? We know the most. So the reimbursement pieces have been limiting, and you're going to see some other important pieces that have been limiting, but that's the rational way to do this. What are we stuck with right now? Doctors are picking all these unnecessary tests because they don't know. That's just the way I worked up this disorder all these years. They got cystic fibrosis, they do a sweat chloride. Oh, okay, 63, I'm done, I got it. No, you're not done. You got to dig further, right? So people have dozens of approaches. Low back pain, goodness gracious. How often do you get the images? Do you need an MRI? The person you saw last makes you better, right? So the chiropractor is your best player, right? So there are dozens of approaches to this same problem. And oftentimes, when I get cases having a clinical practice in coagulation as well, I look at it and say, you know, they could have done one killer test. And they played with this for like 3 months and did everything around it, and it was simply von Willebrand disease. What the heck happened here, right? So the landscape is changing rapidly. Is the interpretation for coagulation testing rarely needed? Now, I will say, Bruce and I are very good friends, but he's needled me for like 2 decades about this and said, well, you know, coagulation is kind of a little thing. Okay, I'm going to show you how this is not a little thing. Okay, if you don't have a stent yet, right, you may get one. You probably know somebody who's got a stent. And guess what? What keeps your stent open? You better take the Plavix. It's not going to be the aspirin. Plavix or another ADP receptor inhibitor to shut off the platelets is really important. And what we've known for years, look at this, 2004, we've known for 8 years that there's a whole bunch of people who, when they take Plavix, it doesn't seem to work because they get a cardiovascular event at 6 months. So clopidogrel, that's Plavix, non-responsiveness is associated with a bad outcome. Okay. So there is a variable response. Some people take clopidogrel and they get better right away before surgery. That's not supposed to happen. It's supposed to keep your platelets down for days. Here's the way it works. Here's clopidogrel. It is a prodrug. When I swallow it, it doesn't shut off my platelets. It has to go to my liver. The liver makes it into the real drug. In fact, this enzyme in the liver, CYP2C19, makes the real drug that goes to the ADP receptor and knocks it out. Okay, so in 2009, big paper shows up in the New England Journal that says some people have that enzyme in the liver, it's broken. So they take Plavix and it's like taking a sugar pill. Except the Plavix is keeping their stent open, and you know what? All those people that have stents who don't know their CYP2C19, they are the test tube. They are the test tube. So what happens is, how do you find out if the test didn't work? Their stent occludes, and then they die or get worse myocardial infarction. So wouldn't it be a good idea to do the lab test to see if you actually take Plavix and it turns into the real drug to keep your stent open? So here you go. So at Vanderbilt, we have a big pharmacogenomics program. We got 4 drug-gene interactions already. We're working on a whole bunch others. So samples come in. And for Plavix, following the warfarin experience where people have said, well, we don't need the pharmacogenomics for warfarin because I can get the INR in range and anticoagulate people, but there's no INR equivalent for Plavix. So the only way to do this then is to take everybody who's going to come in and see if Plavix will work. And guess what? There's an alternative drug that costs the same amount of money. So for $5 or $5, if it's not Plavix, we'll switch you to prasugrel. Nothing lost, right? So now everybody who gets interventional cardiology at Vanderbilt gets their CYP2C19 automatically. And in fact, if I go to my primary care doctor and Bill Maynard says to me, you know, Mike, your cholesterol's been elevated for kind of a long time here and your stress test is not looking so good, we think you're probably going to get stented later, they will do my pharmacogenomics now to find out if I'm going to be sensitive to Plavix. So immediately I would get started on the right drug. But it got complicated, didn't it? Ooh, these are the alleles. Boy, you give this to a primary care doctor. What does star 1 mean, for goodness sakes? Is star? What is a star? Well, that's an allele. What's an allele? Honest to goodness, what's an allele? Okay, so then what we ended up finding out is that it's not just star 1 that works and then star 2 that doesn't. Uh-oh, all these appeared. And then 17 was a gain of function. Okay, pretty doggone complicated for stent patients. For stent patients. So if we're really going to do this, we could just leave it the way it is, take your stent, good luck. You're either going to occlude it or not. You got a 1 out of 5 chance. That's not bad, right? I mean, 4 out of 5, you might not occlude your stents. Crazy. So we have decision support, which is the usual stuff, right? Where we come in, and I know you can't read it, due to increased risk of bleeding compared to clopidogrel. Prasugrel should not be given to patients. A little increased risk for bleeding, not much. But then if they don't use it, they have to send us a reason why. And we're counting up everybody who doesn't switch. And when you don't switch, somebody calls you up and says they're on the wrong drug. Even with this level of decision support, the doctors still want the test result interpreted. They want us to say, you have star 2, star 17, gain of function, loss of function. You could stick with Plavix if you want, but better to switch to prasugrel. So even with decision support, they want the interp. Why is it that if you could call up a rheumatologist for lupus, right, and you got somebody who's autoimmune disease and there's a primary care specialist interaction, how come we can't do that? We have the knowledge base. We need this basic functional unit. Now, 10 years ago, we did a survey, now 12, at the MGH to look at the benefit of these. And I know some of you have seen these slides. It's 100 of 100 surveys that we got back. It was electronic. And we said to the docs at the Mass General, if you saw a patient and got an interpretation, would you fill out this survey? What did we learn? We learned that when we interpret the test, just like radiology, I mean, really, do we give back the MRIs? Do we cut the sections in histology and then take that lung and give it back to the surgeon and have the anatomic pathologist say, call me if you have a question? No, it's ridiculous, right? But what do we do for everything else? We're going to give them Plavix star 2, star 16. I mean, is that any difference? And then we say, and you got 9 hours of education in medical school about this, right? And you didn't have an exam, so go ahead. And the patient's life depends upon it too. So we're going to put all those pieces together. So yeah, they said, gosh, it saves us time. It tells us that impacts the differential. You can tell us what it is so we don't make a mistake. Reduces the time to diagnosis. Look at some of these others. Reduces lab testing, medical procedures. This is a small bar but big dollars. We kept some people out of the hospital. According to this survey, better medication use and blood products. Here was a big deal. See, we did reduce specialist consultation. As one of my ENT friends at the Mass Eye and Ear Infirmary said, I used to call a heme consult when I had a kid whose tonsils had to come out because often you get a prolonged PTT with what we've learned is a factor 12 deficiency that doesn't make you bleed. I had no idea about that. I used to just say, oh, the PTT is long? I'm not doing surgery. Call a heme consult. We waited 3 days. Then all of a sudden, one day, I got a paragraph, and it said, your patient has a prolonged PTT, the mixing study correct, we did factor assays, it's factor 12 deficiency, this patient won't bleed, the patient is cleared for surgery. He said, I can't believe it. It's all right here. And then they did the surgery, and there was no excess bleeding. So he said, we don't get the consults anymore. So it did reduce consultation. However, we also found people who had bleeding disorders or clotting disorders that were never explained, who needed somebody to take care of them for the rest of their life. And guess what? We sent them off to the hem-onc doc who was going to do that. George Lundberg was at a CDC meeting about 6 or 7 years ago. And he said this, and I thought it was really insightful. He said, you people in pathology did not do what the radiologists did. He said, let's face it, when radiology had a chest x-ray, a belly film, and bones, all the internists and surgeons knew how to read the stuff. What did the radiologists do? They bought the film. Okay, that was it, right? And they passed the inspections. There wasn't much to do. Maybe there was a tough x-ray, right? But bottom line is they did not systematically interpret. But then the MRI came and the CAT scan. Suddenly it became too complicated. And the radiologist jumped in and said, we're going to be clinical. That's it. We are not going to just run the radiology suite. We are going to interpret systematically everything that comes through. So what happened when our stuff got complicated? We just stuck on those inspections, and we bought better equipment, and we put in the lines, and if they called, we answered, right? But people aren't calling, they're guessing. So that's the problem. Look what behind the black glass interviews have shown through the CLIC committee. You don't talk to a radiologist or a pharmacist in a hospital. You're talking to a colleague. Talk to a lab, it's a black box. I don't think about calling the clinical pathologist. They don't help me. I don't even know who they are. And forget about calling the laboratory. So clinicians across the U.S. are asking why pathologists aren't helping them pick tests and say what they mean. What's the answer? Okay, the DMT. So what it is and how it was created, the first thing I want to tell you is what it's not. I've given this talk a whole bunch of times. It's grown as we've done more. But I will tell you that lots of people have said to me, we're doing that. And I said, really? You're doing that? Okay, so tell me what you're doing. Well, here's one. We get the lab test result, but we actually don't look at the clinical record. So if you have factor V Leiden, a 26-year-old on oral contraceptives, or a 96-year-old who had a stroke, same story? Really? Really? Second, the service doesn't meet on a regular schedule. Yeah, we have COAG rounds. We do it like once every 3 weeks we have a session. That's just a teaching session. The interpretation isn't written. Micro is perfect for this. You walk through the micro lab and somebody says, Aspergillus. Why don't you write it down? Put it in the record. Tell the whole story. There's like 25 people taking care of this patient. Why is it that we in pathology take people through the micro lab and say, see that plate, see that plate, see that plate? That doesn't help. We're not a curbside consult service. We're like everybody else. And the last one is the one that I like the most. The interpretation is so self-evident, it's not clinically valuable. Somebody from Scotland told me, we interpret every test result in our country. Come on. By the time I got back to the office, he sent me a stack. It was this thick. I looked at the first one. I look at the page, looking for lab data, cholesterol, 525. There's a little box that says interpretation. You know what it was? Hypercholesterolemia. Come on, really? I mean, you got to say more than that. If you have a low value, explain why it's low. If it's a high value, do the same. Okay, so having said that now, these are the barriers. Now, I will tell you that I've faced every one of these barriers, and these barriers have been introduced to me by everybody who's heard these talks. Number one, anatomic pathology has figured out a way to pay for itself over these decades. You look through the microscope, you make enough money to pay for that salary. That's just the way it's reimbursed. How wonderful. And guess what? Clinical pathology has been held to that same standard. So if I'm getting paid $25 for going down to the emergency department and stopping somebody from losing a unit of blood an hour through a chest tube, $25 for that over and over is not going to cover my salary. We need a different sense of how this works financially. The leaders at Vanderbilt got it right away. They said, wait a minute. If you go down and do that in the emergency room, you probably save six blood products, 200. Okay, $1,200 in packed red blood cells. Wow! Plus they weren't admitted. You stopped the bleeding. Oh my goodness! Okay, there's another $1,500. So what they realized is that the cost of the total patient encounter was helped hugely by the people who knew the clinical lab, because the clinical lab stuff is in every single case, right? And so what they realized is that a more accurate and rapid diagnosis was big dollars on the other end. So, and almost no one understands that today. You go to your pathology chairs, you go to the administrators and you say, you know, we are saving thousands of dollars by patient encounter, and you can even count it up if you take the time to do it. Nobody gets that. They're still working on clinical pathology has to pay for itself like AP. Second is, it takes some informatics support. I mean, really, if we have to do the interp, think about signing out derm. Melanoma? Nope. Melanoma, yes, okay. I mean, what is that, 15 seconds maybe, right? So if you have to look at all the clinical lab data, so I look at coag, I got all these factor assays and lupus antichrist. If that's going to take me half an hour to sign out, I can't do it. Vanderbilt invested in its big biomedical informatics group a lot of time and energy to create something called Quill. What this does is it goes through our electronic medical record and pulls out for coag all the coag tests and the other ones we might want, like liver function tests, and all the coag related drugs. And for micro, it pulls out different ones. We just tell them which ones to pull it out. So it's huge. What it means is that we can do 20 cases in an hour and a half or 2 hours. So yes, they did jump in. If it takes too long to sign out a case, a DMT is impossible. The informatics people really have to step up. They came to rounds. Bill Stead, who's done a lot of work in informatics for 3 decades, made sure it happened as the Associate Vice Chancellor. There are not a lot of people who are classically trained in laboratory medicine. And I will say a sensitive topic over the last 20 years. The College of American Pathologists has the MDs, right? So that means that if I'm an MD and I interpret a coag, I actually get paid. Maybe it's not as much as AP, but they'll pay me. If somebody who has a PhD in toxicology looks at a gas chromatograph and says, whoa, that looks like a drug of abuse, and I know the guy said he was taking cough syrup, okay? Don't they deserve to be paid for that? We pay PhD clinical psychologists. What's the matter with paying the people who know the most about it? Vanderbilt decided to go degree blind. Whoever knows the most can lead a DMT. So we have MDs, we have PhDs, and now we're involving the techs. And I gave the keynote address to the American Society for Clinical Laboratory Scientists, and I said, if the pathologists aren't doing it, you need to step up. If you are the only person who can say to that ENT surgeon, the PTT is prolonged, it's factor 12 deficiency, and they don't bleed, somehow we have to figure out a way for you to tell them so that that kid doesn't get 2 units of somebody else's blood. Somebody has to step up to help the patient. So the fact that it becomes degree blind is related to the money. So if payment for the consult is less relevant than the savings from a quick and accurate diagnosis, all qualified individuals should be invited to help establish the correct diagnosis. The last thing, the difficulty in quantifying the financial benefit. This is an interesting thing. Now, fortunately, Vanderbilt is all one campus, and the Owen Business School is right next to the hospital. How perfect. And they're very interested in what we're doing and trying to demonstrate its benefit. Now, I want to contrast it with this point. Nobody ever really said, when somebody came up with surgical pathology and said, oh, by the way, nowadays, when you have a lung lesion or a breast lesion, we're going to biopsy it and look at it through the microscope. So you just don't remove the breast. Really? You could find out if it's cancer. I wonder if that's valuable. Maybe we should prove it first, right? Nobody said that. When the MRI showed up and they said, wow, we can see that this lesion's calcified and spread to this. They didn't say, wow, we better study that for 3 years before we can do it. Then how come when we can give you a conclusion about a Plavix pharmacogenomics or you pick it, autoimmune disease, we tell you right away, somebody says, you better prove that. Okay, well, thank you. We're going to do it then. So I think that the reason why we're being asked to prove it is that our field, we're sort of stuck. People for the last 30 years were trained in anatomic and clinical pathology, and you got paid to do anatomic and you didn't get paid to do clinical. So who in their right mind would learn strictly clinical pathology? A few of us interested in informatics, coag. I went to the MGH with 2 research grants. They had to come up with less money than they had to come up with for a Surge Path fellow to hire me because I had the money on my research grants. right? So this is the way people ended up doing straight clinical pathology for so many other years. They got funded other ways. So the problem is that with a field that's mostly trained in anatomic path, that's made a pretty good salary now, we have trouble because they don't want to do it. And everybody thought if we don't do it, the pathologists, the medicine people will go in and interp. No, they're not doing it either. They don't know it either. The fact is everybody's pointing to us, you run the lab, tell me. I mean, I got a positive anti-nuclear antibody test. Do I need anti-Rho, LA, Jo1, topoisomerase, or what? I mean, tell me. Don't you do the test? Tell me which ones to pick. So that is the problem. I think that our own field has said we're not doing it. Okay, what do we got? So these are the existing and planned DMTs. Here's a picture. This is the coag lab. We get people who have strokes and all sorts of coronary artery disease, blood clots and bleeding problems, women who are infertile, people who have autoimmune disease who might get clots. We allow for diagnostic test selection algorithms. I went to the medical center medical board. We did this at the MGH. I did it at Vanderbilt. We reduced hundreds of tests into work up my prolonged PTT, figure out why my patient is hypercoagulable. There's like 6 things, and they pick from them. They love diagnostic test algorithms. And we get the right test, and we have a lot of choice then in picking them. Multiple attendings, I share it with 3 other people, so I do 3 months of the year. An expert-driven, patient-specific interp comes out, and I'll tell you more about the financial benefits in a minute. Now, I just want to move over to something that could be called classical anatomic path for a minute. This is heme path. We have looked through the microscope and said that looks like acute myelocytic leukemia for a long time. But guess what? We have cytogenetics, flow cytometry, and molecular that all goes in there. What happened is the oncologist would get a call and say, I have a patient, the nurse calls, coming from Kentucky. We think they have ALL. What test do you want? So they say, get them all. The molecular tests are expensive, right? Just get them all. Then they find out it's not ALL, it's AML. Well, that's like taking thousands of dollars and putting them through a paper shredder. And we just used up all that tech time to do the wrong molecular test. What a waste of time. So you know what they said? We don't want to order the test. Let the pathologist order the test. Really? Us? Yeah, look through the microscope, order all the tests. If we want to add in any, we will. Well, there's a real change in how this system works. So what happened is they put together the interpretation, and this synthetic interpretation is what is read. And this we don't get paid for. You don't get paid for synthesizing the interpretation. When you take the cytogenetics and the flow and the molecular and put them all together, there's no payment for putting them together. You got paid for these individual pieces, but not this. And so let's just look for a minute what happened. This is prehistoric data, 2010, data from Adam Siegmiller, who's one of the hematopathologists, and I know you can't read this, but these are all individual patients. Recurrent AML. Did we do the karyotype? It's checked. Did we do the FISH? It's checked. And what happened? Mia Levy, who's an oncologist in informatics, said, let's make a dashboard. These are the patients' names covered. And as, for example, there's cytogenetics, done, 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 done. It's in green. When this goes to the end, a buzzer goes off, sort of a virtual buzzer. The hematopathologist signs out the case. We got all the pieces. The oncologist doesn't keep calling and say, do you have it yet? Do you have it yet? Is the cytogenetics back? They look at the dashboard too. So now with this dashboard concept, we can really connect. So the good part about this is that they just order bone marrow testing panel. The pathologist orders all the laboratory tests, and then the oncologist has an option to order something a la carte. This figure is really the summary figure for the savings. Yeah, that doesn't look like much the way it's drawn. It's $284 less when we do the testing, which we call reflex testing in HemePath. And for the number of bone marrows, look at the dollars. It's hundreds of thousands of dollars. So really, really dramatic. Now, if you save money on doing fewer tests, it's easy to show the savings. What if you do more tests, but you get the diagnosis sooner? That's a little harder, right? What if you just have good clinical impact? What if you tell a woman who's lost 6 pregnancies that she has a hypercoagulable state, and you anticoagulate her and you carry her to term, right? What's that? What did we save there? Not a doggone thing. We even spent money, right? So when you look at that, the easy things to do are the reduction in test numbers, and that was why HemePath got a big hit right away. Now in microbiology, and the big arrow here is infectious disease, but we get data from lots of services, and we have multiple attendings. We have an expert-driven rounds. We hope to show an improved use of antibiotics and a decreased length of stay. Data forthcoming. We do not interpret every E. coli urine culture. Look what we're interpreting in micro. If you have that bug in that organ, you are going to be really sick. If you have that bug, you could die from it. You get down here and you say, whoa, you're on the right antibiotic, but you are getting sicker. All of those go between 1:30 and 3 o'clock every day with the 3 micro attendings in a room with the micro fellow, the micro resident, and the cases get signed out. The transfusion medicine people have long met, but now we've formalized this a good bit. This is Heme-Onc up here, and the emergency department and the ORs use a lot of blood. And what are we giving? Interpretations. I'm going to show you what they are in a minute. We hope to show that we're using less blood. And importantly now, we are evaluating people who had gone to the OR with a prolonged PT or PTT, a low platelet count, a positive bleeding history. What for? I mean, you tell us on Monday when you see them prior to their surgery, and then on Wednesday, by Wednesday, we have it figured out. And then we can say, that's your bleeding disorder. Give them DDAVP before the surgery starts. So that is the idea. Transfusion medicine, I'm just going to show you briefly the predominant case material. It is a note in the record. It is not a curbside consult. They sort out every day at rounds between 9:30 and 10:30 every transfusion reaction and make a note in the chart. They also will talk about every red blood cell antibody that has been identified and find out the availability of blood products. They also review every single massive transfusion protocol, what was the indication, and was anything wasted. And they will talk about every Rh negative patient who gets an Rh positive product and whether or not Rh immune globulin is necessary, and every single error is discussed in real time. So on the drawing board, for anatomic pathology, we've already met for breast, so I will tell you the way this is going. HemePath has molecular, cytogenetics. Why aren't we going to do that for the other cancers? Why not? We got the breast people together. The breast surgeons, the breast radiologists, the breast pathologists, the molecular people. The DMT will be shaped this year for breast. We have a champion radiologist who's going to be able there to contribute mammogram and MRI findings. This group will meet every day, and we are going to march through the cancers. Lung cancer is going to follow breast cancer because of all the molecular tests and the association with which chemotherapy to choose, and neuropath is right behind. So what do we have right now in lab medicine, a group which I'm organizing? We have coag, transfusion medicine, and micro. We're making these even better. And endocrine, tox, and autoimmunity are on the runway and should be done in 18 months. In anatomic path, we have heme path, breast cancer, I mentioned neuropath and lung cancer, renal path, and all of these genetic morphologic associations are going to be tackled in DMTs. Now, some people have said, you're doing this by laboratory area. There's a group in Massachusetts, a hospital, that said, very intrigued by the DMT consult, but we need a DMT for obesity. I said, well, we don't have a lab for obesity. They said, yes, but what you do with the DMT is you standardize the medical approach. So why don't we bring the cardiologist and the endocrinologist together in the same room, and maybe we could manage these patients in a totally different way. We haven't gone there yet, but I think it's very intriguing that you take the most common abnormalities, obesity, diabetes, lower back pain, cardiovascular risk, and think about DMTs in those areas. So coag rounds, I want to give you the logistics. So today, first thing in the morning, somebody went to the coagulation lab, one of our residents. And when the resident went to the lab at 8 o'clock, they conferred with the technologist who said, today we have 21 cases. And they have all day to read the chart, show up at 4 o'clock, and if I'm the attending, somebody else is obviously the attending now, they present their interpretation, just like they do for AP. Yeah, I looked at that. I thought it was a tumor of this kind. Nobody shows up and says, I couldn't figure out that one. It's too embarrassing. There's like 6 people in the room. So you have to say, here's my interpretation. So just as in any other thing, surgery, medicine, the attending confers and says, all right, let's finalize this. So 4 p.m., everybody gets together, and the attending says, oh, let me tell you about Plavix pharmacogenomics, because that's the case we're talking about. And there's an education session. This is how the residents really learn. On June 30th, 2010, this is what the doctors at Vanderbilt got for a particular case. And I want to acknowledge Mandy O'Leary, who's sitting back there, was a resident with us at the time, because she helped make a lot of this happen. And so I asked the doctors, do you even have any idea what P plus NOHR stands for? No idea. No idea. So, but you're using these things, right? Yeah, we are, but we have no idea. People just abbreviated stuff. We have no idea. I said, so what do you do with this? They said, we look for the asterisk right there. Right there. Okay, there you go. So I got a prolonged PTT and something that's RVVT is abnormal. So we never did this. I will tell you the commercial labs who do a marvelous job, this is what they do. They don't know the patient, I mean really. But this is just annoying. This is the paragraph on what is a Russell Viper venom time. Okay, you look at it and you say, okay, maybe. I mean, do we do that in anatomic? Ductal breast carcinoma. Get the Robbins, what is it, page 972. Copy that doggone thing and put it in the chart, right? Nobody's doing that, right? So here's what we gave him on July 1st. This patient has an elevated PTT with a normal PTINR and the thrombin time's okay. We did a mixing study. It's all algorithmic. It failed to correct into the normal range. We thought there was an inhibitor, like a lupus anticoagulant, so we did a test for it, and it was positive. Taken together, the PTT is because the patient has a lupus anticoagulant. As soon as this happened, my phone rang, and it was one of my neurologist friends, and he said, Mike, this is Derek. I just read something. He said, underneath the numbers was this paragraph that I understood, and guess what? The nurses understood. And he said, is this like the only day you're going to do this? And I said, Derek, we are going to do this for the rest of your life. And so, so that was what happened. The trainees are the ones who, residents or HEMONC fellows who are friends now. This is a great way that teaching is merged for COAG. They look at the record. They provide that draft of the interp in clinical context. The attending's responsibility is to finalize that, and then it goes right into the medical record. The medical technologist helps. They will say, whoa, you know that protein C that's low? The patient's on our Gatraban, and our assay is a clot-based, not a chromogenic base, so that's going to have an interference. Oh, thank you. Yeah, the PT is long, but I think it was almost quantity not sufficient. And what is the stay clot LA? Gail, can you go to the board to show us? And so the tech is very valuable in this. And here's the other interesting part. So Bill Stead is the informatics leader who's done this for a long time at Vanderbilt. He said, we need the librarians at rounds. I said, come on. Really? The librarians? So he's got a whole bunch of information scientists, some of which are PhDs, and they came to rounds every day, COAG rounds for like months. Now they do it 2 days a week. And we get to these points where we don't know. I mean, really, what is that? I mean, a factor V inhibitor, right, that's not an antibody, is it associated with... Bingo. So we come up with 5 questions about it. They created a site here, informatics, it's knowledge management, and we have a site, Diagnostic Management Team Database. We can click on up to date or look at some summaries that have been written. Let me show you the next slide. So these are questions we have asked. Does Tylenol interfere with platelet function? We ask that question every now and then when we get patients. So we saved that. And antiplatelet therapy, here's aspirin resistance questions. So we built a database of common things, and there's 2 ways to ask a question. You can either submit the question, and if they're not there, they give you the answer in 24 hours or less. Now what is this? Yes, they search 50,000 journals, and what do we get? What do we get? So here's 20 lines. This really is based upon a question of should we anticoagulate somebody who's got a clot on the outside of their leg. For years we didn't. And then the evidence suggested that maybe 1 month, not 6 months of anticoagulation is a good idea. Some people were given 6 months of anticoagulation. I said, what's the status of the field? They put together this, which summarizes about 4 papers. If I click on this, I actually get the papers. So it is totally invaluable, and so we get the links. Now, what kind of cases do we have? We work up prolonged PTs and PTTs without them telling us which factors they need. These life-threatening illnesses, heparin-induced thrombocytopenia and thrombotic thrombocytopenia purpura, we diagnose or rule out. We will tell you why somebody has a clot in the legs or the lungs and what their hypercoagulation status is. We will tell you why they bleed, whether it's von Willebrand's disease, your bad platelets, a coagulation factor deficiency, or DIC. We will tell you if this stroke patient needs aspirin or Coumadin based upon whether or not they have a hypercoagulable state. We are now the first line for why does this woman not carry to term. Before it was a radiology study, now it's a hypercoag profile. So now we can tell people this is it. She has 2 hypercoagulable states, and now we can help people carry to term. We will tell you if you're up for a kidney transplant, you better really be careful about this patient because they're hypercoagulable and they can clot that thing off as soon as you put it in. We'll tell you about the patient with lupus and their risk for thrombosis, and this one is big. I don't know if any of you have heard about this, but obviously missing child abuse is a big deal, but overcalling it is even worse. Now you pull a child who's loved from the home of parents who did not hurt the child. It turns out that I got involved in 2 cases that just showed up at diagnostic management team rounds, and we fixed the overdiagnosis. And the father's story of a minor injury explained the big bleed because the kid had a bleeding disorder, right? At which point there was a fellow in prison, Ernie Lopez, 8 years in a solitary confinement in Texas, and he had a baby for 20 minutes who had rampant DIC, was handed to him, infected, by the kid's mom. And the kid bled from everywhere, and he was the only one there, so they assumed he beat and sexually abused the child. That showed up on television, and now I've got like 35 cases. This is a really hard thing to listen to. And I will tell you that the overdiagnosis is horrible, and there are doctors out there doing a PT, PTT, and a platelet count, finding nothing, and sending dad to jail. And there's a big list of coagulation disorders. We have a non-accidental injury panel. Everybody, all the attendings do it. Every place should do this. Now, as I mentioned to you, better diagnostic test selection, improved patient outcomes, more difficult to quantitate. This is our impact review. This is just 19 days of cases. Here's some impacts. How much did we save in dollars? I'm not sure. But we told you why you had a bunch of clots or lost a lot of babies. We said, oh, wow, we don't know you've been bleeding, why you've been bleeding, but here are the 16 tests that you ought to do. We've changed diagnoses. We've said your vaginal bleeding is probably endocrinologic, not clotting. And we've said maybe you have a platelet function disorder because of a drug. And so the clinical benefit to patients is apparent. The chief of medicine at a big meeting in our section heads group for Vanderbilt raised their hand and said, could you just DMT the entire pathology service, all of anatomic path and all of clinical path? So the preliminary observations from a before and after study done by Larry Van Horn, I'm just going to show you it's 6 months before and after COAG. He looked at all the DRGs. The 2 that changed were pulmonary embolism, a clot in the lung, and also intracranial hemorrhage. Intracranial hemorrhage was more apparent with non-parametric analysis. But look at the length of stay. Cut a day, 3 days to 2, 4 days to 3. Here is their thought. They said before diagnostic management team rounds, we ordered tests on Monday. They came back on Tuesday. We thought about it. On Wednesday, we took an action, and on Thursday, we discharged them. Now the tests are ordered. They're interpreted by 4 o'clock on Monday. They get an answer. They read it, and then on Tuesday, they clean up the patient and discharge on Wednesday. Here are the data. This is total charges. This is length of stay. The red is before rounds. Notice they spread out way over here. High cost, big length of stay. The green after rounds, much more coalesced to the lower left, and here is intracranial hemorrhage, same story, so we're shortening the length of stay. So yes, largely a length of stay shortening, and is it because the diagnostic latency, because they're talking to us more, or because we're more visible? And finally, I just want to give this concluding thought. People are making a lot of money doing this. The CAP Strategy Committee has said The world is changing. We have great digital imaging. There's a lot less money. We spend a lot of money on health care. And if it really is a money thing, we're going to be doing a big scramble to figure out how to learn this in a hurry. There are a lot of people involved now. This used to just be me. The Vanderbilt team is big in the pathology leadership and in the medical center, health economists, information scientists, nearly 20 DMT leaders. Thank you very much.